Hi, Dr. Nicole. You can now begin.
And today I'll be talking to you about microbial keratitis, diagnosis, assessment, and clinical management. This is intended to be an intermediate level lecture, so we'll assume that you know what corneal infections are, and we'll briefly discuss terminology and epidemiology, but then talk about some fundamentals as well as intermediate level knowledge on how to diagnose, how to clinically assess, and then based on that, how to manage infections. So here are my disclosures. First, let's do a quick, rapid deep dive into the epidemiology of infections. I think this is important just to set the stage for the fact that these are really very important diseases that are neglected in terms of research, in terms of development of new diagnostics or therapeutics, and also, as you'll see, they're underappreciated in epidemiologic surveys. Corneal blindness in general affects about 6 million people worldwide and is the fifth leading cause of blindness. And within that category of blindness from corneal disease, infections are by far the biggest cause. And they can cause anywhere from 1.5 to 2 million new cases of unilateral blindness every year. Developing countries tend to be underrepresented in global surveys, and so the real burden for various methodologic reasons is likely underestimated. For infectious corneal ulcers, a review noted that even the most basic data, like incidence, prevalence, contribution to disability-adjusted life years, and loss of productivity indices, all remain unknown. The only data available comes from outdated population surveys, which suggest that South and Southeast Asia are the epicenters of disease. But inclusion of infectious corneal ulcers with a broad category of corneal opacity has not provided the detail required for accurate epidemiological study. And so, a group of infectious keratitis experts in recent years have proposed that infectious corneal ulceration be classified as a neglected group of tropical diseases for these reasons. The World Health Organization surveys define blindness as visual acuity that is 2400 or worse in the better seeing eye. But what that means is that monocular blindness is ignored. And what that means also is that infectious keratitis and the burden of that disease is ignored. The mean age of onset for infections is 45 years, so they tend to affect younger patients who have a lot of earning potential and the need to support their families. They suffer a lot from social stigma from the corneal scarring resulting from infection. And of course, that has severe adverse consequences for their quality of life. The surveys that do exist that try to estimate the incidence or prevalence of microbial keratitis show highly different results depending on the region of the world. So in Minnesota, a survey back in the 1950s showed 2.5 cases per 100,000 patients. A later study in the 1980s showed 11 per 100,000. In Scotland in 1995, it was 2.6 per 100,000 patients. In Nottingham, in the United Kingdom, the range was around 34.7 per 100,000, ranging from 2007 to 2019. And in Portsmouth, UK, it was about 40 cases per 100,000 people in 2006, and about 27.6 per 100,000 in California. But when you go to the other side of the world, you see the numbers are very different. In Madurai, India, back in 1996, it was 113 cases of corneal infection per 100,000 patients, 710 per 100,000. So really orders of magnitude greater than in Europe and North America. In Myanmar, 339 per 100K in Bhutan, 799 per 100,000 in Nepal. And in Africa, there's very conservative estimates, extrapolations are that there are around 75,000 cases of fungal keratitis alone. And fungal keratitis is actually one of the leading causes of enucleation or eye removal in Africa. So how common are corneal infections? The data is highly variable, as you can see. In developed countries, the incidence and prevalence might be lower, although it's still a major unmet need in terms of diagnostics and therapeutics and preventing blindness. And in developing countries, the numbers are far worse. And so for these reasons, the corneal ulceration in the developing world has been referred to as a silent epidemic. And the concern is that we're only really seeing the tip of the iceberg as far as the burden of this devastating blinding disease. Next, we'll talk about specific microbes in culture-positive microbial keratitis. Microbial means bacteria or fungi or parasites. And so you can see here that when you look at the regions and you sort them by what proportion are fungal versus bacterial, there is a bit of a distribution here where China and India and other parts of Asia have more fungal keratitis, sometimes exceeding 50%. And other parts of the world have more overwhelmingly bacterial keratitis with a very small proportion of acanthamoepic keratitis. The risk factors are well known. Contact lens wear is a big one, especially in developed countries, as well as increasingly in developing countries. Contact lens associated keratitis has had a stable absolute incidence since the 1980s with 2 to 4 cases per 10,000 contact lens wearers. But given that there are millions of contact lens wearers every day in the United States alone, that means there are many cases of infectious keratitis due to contact lens wear. Daily contact lenses are associated with lower risk and less severe cases over time. Ocular trauma is a major risk factor. A classic case of bacterial or fungal keratitis would be an agriculture worker, and this can happen in India or Africa, but also very commonly in America and developed countries as well, where somebody has an occupational injury from working in the fields or working manual labor, and that results in infectious keratitis. Fungal keratitis in particular is notorious for being caused by vegetable matter trauma in farmers and laborers and can also be precipitated by use of traditional eye medications. And ocular trauma more commonly is associated with bacterial keratitis caused by gram-positive commensal organisms. Recent eye surgery is a major risk factor, a well-known particular form of keratitis that is associated with procedures as Mycobacterium chelonae infection after LASIK. Ocular surface disease is another known risk factor due to the overgrowth of bacteria on the ocular surface and the eyelid margin. Topical steroids are another risk factor, along with immunocompromise. And Candida keratitis is one example, but there are many others that can occur after keratoplasty. There are some broad categories of infectious keratitis, bacteria, fungi, protozoa, and viruses. And we're going to be covering all 4 of those in terms of diagnosis, assessment, and more specifically targeted treatment. But let's talk about the epidemiology of bacterial keratitis. So the bacterial genome is large and diverse, but the gram-positives and the gram-negatives are the 2 broad categories that we sort them into based on microscopy results. So here are the most common causes of bacterial keratitis. Number 1 is coagulase negative staph species. Overwhelmingly, this is across many prevalence surveys. This is the most common cause of bacterial keratitis. And number 2 generally tends to be Pseudomonas species. And then there are others like staph, strep, nocardia, enterobacteriae, and H. flu, and Serratia. So the epidemiologic trends, though, are that there is markedly increased incidence from the 1950s to the 1980s in the occurrence of bacterial keratitis. By the 1980s, over 80% were associated with contact lens wear. 30,000 new cases occur in the US alone, which is a staggering number, and over $20 million a year are spent treating bacterial keratitis in the United States alone. Newer trends are that there are some reductions in contact lens related cases in some centers and more increase in ocular surface disease related infections in some other centers. And there are numerous reports of increased antibiotic resistance and increasingly its association with worse clinical outcomes. Moving on to fungal keratitis, there are broadly 2 categories, filamentous and yeast. So filamentous tends to occur more in tropical or humid climates like in Asia and Africa, but there's plenty of it to be found in more humid and hot parts of the US as well, including in the mid-Atlantic region where I practice, as well as more southern climates like in Georgia or South Carolina or Florida. Temperate climates tend to have more yeast keratitis. So at our center, Candida keratitis, which is a yeast form of fungi, is one of the most common causes of keratitis, and that's also true in other northern centers in America as well. The most common forms of filamentous keratitis are Fusarium, which tends to be quite severe, Aspergillus, and Curvularia. And for yeast, it's usually more Candida, Cryptococcus, and Trichospora, with Candida being the more common one. The trends are that the burden of disease is substantial. There are 1 million new cases of fungal keratitis per year globally, and that was an estimate from 2020. 60% of eyes with fungal keratitis go blind despite treatment, and 10 to 25% of eyes will perforate or require surgical removal. So this is a very severe unmet need in terms of therapeutics as well as diagnostics. Fungal keratitis may be increasing globally. There's an increased proportion of fungal keratitis reported in Thailand, Nepal, Ghana, and India across multiple studies. There are increased absolute numbers of fungal keratitis in the US and the UK. In our own center, we are seeing increases in the proportion of keratitis that is caused by fungi. And there may be some relation to climate change. There's a correlation, at least, with increased systemic fungal infections. And we know, at least in one report from Egypt, that humidity levels are correlated to increased fungal keratitis incidence. There are some trends to be noted for acanthamoeba keratitis as well. So the burden of the disease is 1 to 33 million contact lens wearers per year are at risk potentially of getting acanthamoeba keratitis. And the infection rate is 17 to 21 cases per 100,000 contact lens wearers in the UK. And what's notable is that this risk is 10 to 15 times higher in the UK than it is in the US. The trends are that in the US, there's a tenfold increase incidence since the original outbreaks were reported. And in the UK, there's a threefold increase incidence from the 2000s to the 2010s. And there have been more severe presentations, more treatment resistance, and more treatment failures as well. And contact lens wearing middle income countries may also be a factor to play. In viral keratitis, risk factors tend to be older age, immune compromise, white race, and atopy. HSV keratitis has shown no major increases in incidence from 1976 to 2007. With zoster ophthalmicus, though, the story is different. There's an increased incidence, threefold increase over 14 years from the 1990s to 2010s in the US. Increased incidence among all age groups, even the young that are not even eligible for shingles vaccination. There's younger age of HDO presentation, and there's possible reductions in population-wide immunity, although that theory is controversial and not yet definitively proven. Let's talk about nomenclature. So here, I think if there's one theme I can try to impart over the rest of the lecture, it is the importance of precision and use of terminology and clarity of thinking and our use of words, our use of diagnostic techniques, etc. So the term corneal ulcer is roughly synonymous with corneal infection, but I would urge perhaps moving away from using that term indiscriminately and being more precise with the terminology. So corneal ulcers, if you think about the definition of ulcers themselves, they're just removal of the surface layer of tissue, whether that's epithelium in the case of cornea or epithelium and keratin in the case of a skin ulcer. These can be caused by infections, inflammations, or even in the case of cornea, nerve damage leading to persistent epithelial defects. That could be a lot of different things. And so corneal ulcers do not necessarily indicate infection. And so rather than just saying corneal ulcer, you may want to say something more precise like infectious keratitis. But even there, you can use more precise terminology to improve the clarity of your own thinking as well as communication with your colleagues who are co-managing the patient with you. Infectious keratitis is often a term used in the absence of confirmatory microbiologic testing. And so you can split this into two parts. You can say it's presumed infection, or you can say it's microbiologically confirmed infectious keratitis. If it's microbiologically confirmed, you can then go and say it's confirmed as bacterial, fungal, or amoebic. Whereas if it's viral, it's often more clinically diagnosed, and you can just say, clinically diagnosed viral keratitis. So to put that into a flow chart for you, if somebody comes in with what we might commonly refer to as a corneal ulcer that we think is almost certainly infectious, then we can call it presumed infectious keratitis. At that point, based on the testing you do or don't do, that can determine what sort of terminology you assign to that disease. So if you do microbiologic testing and you have a confirmatory result, there's a group of terms you can use for that situation, that diagnosis. If you do the testing and you have a negative or unclear result, or if you don't do the testing at all, that can determine what terminology you use. If you have a confirmatory result, I encourage you to to label the disease with specific words that say what testing was done and what the result was. So you can say microscopy confirmed gram-negative bacterial keratitis, or filamentous fungus keratitis, or culture confirmed Pseudomonas keratitis, or PCR confirmed acanthamoeba keratitis. You can also say if it's culture negative, you say culture negative presumed infectious keratitis. On the other hand, if it's viral and it's clinically diagnosed, you can say clinically diagnosed viral epithelial keratitis. or clinically diagnosed herpetic disciform keratitis. But I encourage more uniform and precise use of terminology because this improves your own clarity of thought regarding what testing has been done, whether you really know what you're treating, and therefore, that sets the stage for more precise and patient-tailored assessment of disease severity and treatment response. So then you go into diagnosis. So the clinical history is important. We've discussed risk factors, and I think you should ask every patient about this when you first see them for the first time. We'll talk about best practices for corneal scraping, and then first and second line testing. So the question is, when do you perform microbiology testing? My answer to that, the short answer is almost always. We never regret performing microbiologic testing. We sometimes regret not performing testing. But generally speaking, there's no downside to performing scraping with microbiology testing. Obviously, there are very select situations, like a very small presumed infectious keratitis or marginal keratitis that doesn't need scraping. A very obvious, phenotypically obvious case of viral keratitis that doesn't necessarily need anything beyond a clinical diagnosis, or perhaps a very severely thinned case of keratitis where you're concerned about causing a perforation. So you could defer testing in those situations, but generally, according to the AAO preferred practice guidelines, you should perform microbiologic testing when there's a large infiltrate, which they define as 2 millimeters or greater, central infiltrate, which means it could be site-threatening, mid or deep stromal, if there's any melt, if it's chronic and been going on for a long time, if there's anything atypical about the appearance that makes you concerned that this is something beyond just run-of-the-mill bacterial keratitis, if it's occurring after surgery, if it's not improving, or if it's worsening despite treatment. Those are all indications for performing microbiology testing. There are a few best practices with scraping, which in my experience are not adequately followed, and they would improve the quality of our diagnostic yield and clarity of our results if we did them more. And so when you're preparing to do the scraping, you should place a speculum in the eye. These patients are often in pain and photophobic, and so a very slow expansion of the speculum underneath the eyelids will reduce the pain, whereas a sudden placement of the speculum will cause the patient to flinch and be less cooperative during the scraping. A single numbing drop is often sufficient to provide anesthesia for the scraping. You seldom need to put in multiple rounds of numbing, and that's important because the benzalkonium chloride preservative within the drops, such as proparacaine, can actually reduce the diagnostic yield by killing microbes on the ocular surface. Obviously, you need to make sure the patient is comfortable for humane purposes, but also for cooperation. But usually a single number drop is sufficient for scraping. You should arrange all your slides and plates and vials beforehand so you're not futzing around trying to find what's what when you're doing the plating so that you can do an efficient job scraping. Scraping can be done with different techniques. You can use the Kimura spatula with the flame to sterilize it in between applications to the cornea. We often use barred Parker blades, not least because we're not allowed to have active flames in our own clinic. So we use fresh number 15 barred Parker blades and scrape with the flat of the blade every single time, and then plate each blade onto a different culture plate. You can also use calcium alginate swabs as well. And the biggest thing I can emphasize is that you must scrape deeply and thoroughly. Again, if you're concerned about decimetacele or perforation, that might be a different matter entirely. In that case, I recommend taking them to the operating room and scraping under the microscope more carefully so that you have equipment on hand in case there is a perforation. But generally, for most presumed infectious keratitis, you must scrape deeply and thoroughly to get a good specimen because what you're doing is very consequential. It should be taken with the utmost seriousness because that confirmatory testing will greatly enhance the likelihood of a successful therapeutic outcome. If there's limited specimen, you can be intentional about the order of testing. Perhaps there's a small but deep keratitis, small but deep infiltrate where you're concerned about, say, fungal. Well, in that case, you can scrape deeply within that small area and preferentially first put the first inoculum onto a fungal culture plate. Or if you're concerned that there may not be enough live organism, that you can even put that small scraping onto a plate for KOH or calcium-4 white staining with microscopy. But there you can think about where to prioritize your specimen placement if there's limited specimen size. Then the next question is what to test with the scraping. In general, I think these are the three most commonly performed tests with scraping. And so we'll start with microscopy, which in developing countries is still widely performed and is a very valid, perfectly great way to detect bacterial and fungal keratitis, and also with the right stains, acanthamoebic keratitis. It's worth noting that the turnaround time for microscopy is far shorter than culture and even PCR. The sensitivity is high, particularly for fungal keratitis. And with a trained microbiologist or pathologist, you can have species level diagnosis or almost species level diagnosis. And so this is something that is on par with, and in some cases, superior to culture. Culture, I think, has certain advantages. It allows you to have more definitive speciation. It allows you to do antimicrobial resistance testing. And so even if you're able to do a microscopy, if you have sufficient specimen, I strongly urge you to send for culture as well for those reasons. Um, the positivity is highly variable, 40 to 70% for bacterial, 50 to 80% for fungal. But generally speaking, getting a good scraping and good specimen and inoculating it on the growth plate is really the key to getting a positive culture based on the techniques I just described for scraping. Culture can also be done for acanthamoeba keratitis using a non-nutrient agar with E. coli overlay, and that has comparable diagnostic yield to polymerase chain reaction or PCR. Finally, there's of course PCR. You can have singleplex or multiplex PCR. Singleplex means you must pre-specify which organism you're trying to diagnose. Multiplex PCR is not yet widely commercially available or CLIA certified or FDA approved, but it's going to be more of a available service in the future. And you can have a panel of different common causes of corneal infection, which are tested for in that one scraping specimen. And so the sensitivity and specificity of PCR for bacterial, fungal, viral, and amoeba keratitis are quite high. And so if that's available to you, then I would urge you to do so, particularly for atypical organisms or for confirming viral keratitis. AMR testing is underrated, and I think it should be a part of your microbiology protocol that you establish with your local microbiology laboratory. The key limitation, which must be admitted for AMR testing, is that minimum inhibitory concentration or MIC cutoffs are based on serum levels of antibiotics. There is no corneal specific equivalent breakpoint for MIC testing. Nonetheless, higher serum MIC levels are associated with worse clinical outcomes. So the SCUT1 trial showed that each twofold MIC increase was associated with one Snellen letter mean vision loss at 3 weeks, or one entire line of vision lost per 32-fold MIC increase. MIC does mediate the organism to outcome relationship, and it accounts for 13% of the effect in terms of worse visual outcomes in the SCUT trial. MIC does predict scar size with a 0.33 millimeter increase per every twofold increase in the minimum inhibitory concentration in a small pilot study that preceded the SCUT trial. Higher MIC levels are also associated with delayed healing and a 4% risk of enucleation and 5% risk of surgical intervention. So the data, although it's limited, is growing that antimicrobial resistance is a clinically relevant factor in microbial keratitis. Therefore, you should test for it. You can have a close relationship with your microbiology laboratory to be sure to test for your commonly used antibiotics and also, if possible, your commonly used antifungals. It's worth mentioning metagenomic deep sequencing, although this is not widely available in clinical practice yet, and it's also very expensive. So this is a technology that compares the samples, DNA and RNA from your scraping against a genomic library of all possible organisms. And it does allow potentially unbiased detection because you don't have to specify which microbe you're testing for with an a priori hypothesis like you do with singleplex PCR. Early results are quite promising, but there is a high risk of contaminants. It's almost overly sensitive. And so you can pick up microbial DNA and RNA from the environment, from the reagent, or from the microbiome as well. And there's also high cost associated sequencing, and you also have very intensive computational expertise that's needed in your center in order to be able to perform MDS. But you'll see this coming up more and more in future years. Confocal microscopy is also worth mentioning as an initial, in some cases, first-line diagnostic test for certain types of infectious keratitis. So for filamentous fungi, the pool sensitivity is approximately 86% across studies, with a specificity of 81%, and an integrator kappa of 0.88%, which means that generally people agree quite strongly when looking at the same photo as to whether or not there's fungal keratitis or fungal hyphae, as you can see here in this confocal example. Acanthamoeba keratitis is the other condition where if you clinically suspect it and you see some very typical features on confocal for acanthamoeba, then that constitutes a microbiologic equivalent diagnosis. The sensitivity pooled across studies is approximately 88% with a 98% specificity and a moderate, like decent kappa statistic of integrator kappa of 0.72, meaning people generally do tend to agree as to whether or not the confocal image shows acanthamoeba. There are two life forms to be noted potentially on confocal. One is the double-walled cyst, and the other is the trophozoite. It is also worth noting, though, that confocal machines are not widely available at all centers. They're incredibly user dependent. Some of them are no longer being serviced as well, so they're not being repaired or maintained. But the user dependency is a major limiting factor because it does require specialist expertise and experience. And there is substantial subjectivity and interpretation of confocal images. So here's a case where we'll start a poll. So here's a case of a patient where they're referred to your tertiary care center for presumed infectious keratitis. No prior culture was performed by the referring physician. They were treated before they saw you with frequent, hourly, or every 2 hours fortified antibiotics, antifungals, PHMB in case there was amoeba, and in the last few weeks before they were seen by you, steroids. And this treatment overall was 6 weeks. So this keratitis is at least 6 weeks old. Your initial scraping was negative. Confocal is also inconclusive. What are your next steps? Should you repeat scraping while continuing broad spectrum antimicrobials that the patient came in with, or perhaps paring them down? Should you stop all the antimicrobials for a 24-hour period and then repeat the scraping? Should you repeat confocal microscopy? Should you take the patient to the OR for a corneal biopsy to try to figure out histopathologically what's going on? Or given the severity in this limbus to limbus chronic infiltrate, should you perform a therapeutic keratoplasty? Great. So over half of you said what I would have done, which is you should stop all the antimicrobials for a good 24 hours, then repeat the scraping. And this is called an antimicrobial washout period. This is a protocol actually published about from Massachusetts Eye and Ear Infirmary, and that tended to increase the diagnostic yield with the second scraping. And I think this is very important to utilize, especially if you're working at a tertiary care center where you're getting a lot of referrals for patients where the ocular surface has sort of been carpet bombed with antimicrobials for a prolonged period of time. That means all the bugs on the surface are dead, and yet there's presumably some sort of infection going on. The washout period in that case can reduce ocular surface toxicity, enable early promotion of some reepithelialization, but also importantly allow bugs to propagate again so that you can more likely detect something on your next scraping. And so in our center, we do initial corneal scraping and we send it for either microscopy or culture or PCR, usually microscopy and culture. And in the case of viral that we really want to confirm or acanthamoeba, we send for PCR. Or if there's an atypical organism, then we send for PCR as well. And if that's negative, then we consider, especially if they've been overtreated with antimicrobials, then we consider a washout period and repeat the scraping. If they're not overtreated, if there's still a new infection, then we don't do a washout period and we just repeat the scraping right then and there. And then we again send for all the same testing. And if that's still negative, then we consider more procedural interventions, such as corneal biopsy, which we can send for histopathology analysis as well as for microbiology testing. And so that's important because both of those have different yields depending on the situation. In general, with the biopsy, you want to use a small diameter derm punch to partial thickness trephinate at the margin of the infiltrate. So you get some infiltrate as well as some adjacent normal cornea within the same specimen. You can take half of that specimen and submit for microbiology testing. And half for histopathology. And also that trip to the OR is a great opportunity to do more deep, careful, and thorough scraping in order to improve your yield of your scraping. So just because you're doing a biopsy doesn't mean you shouldn't also do scraping yet again. The other thing to consider when you're talking about procedures and their use as diagnostic opportunities is if you're performing a therapeutic keratoplasty for severe non-improving infectious keratitis, then consider microbiology testing at that point as well. So before you go into the eye with your trephination, go ahead and take a small, like a 27 gauge needle, and you can aspirate aqueous, or if there's endothelial plaque, you can aspirate that as well and send that for microbiologic testing. You can also, again, do scraping, and you can also send part of your TPK button for microbiology testing. So when you're doing TPK as well, just like with biopsy, that trip to the OR is another opportunity to perform a good scraping and try to confirm your diagnosis. Next, we'll move on to clinical assessment. So the big elephant in the room, which I wish we talked about more in our field, is that corneal infections are incredibly difficult to measure. And what we also need to acknowledge is that there are many different ways to measure, and different people use different ways. I've caught myself, I'll admit, sometimes using different techniques on the same patient on different days, and that is not the right thing to do. What you need to do when you're measuring these infections is be very precise and standardized, not only amongst within yourself as you measure the infection across different visits when you're seeing the same patient, but also across your colleagues. And so when you document what the exam findings are for corneal infections, think that you are communicating to your colleagues as well as to your future self, and let that be the motivator for good, meticulous documentation of lesion findings. Here are what good slit lamp photos look like. At our center, we have instituted a universal photography protocol where every infection at every visit gets standardized photography with diffuse illumination as well as blue light testing. We like photos that are in primary gaze. For diffuse illumination, here we should have taken the photo without fluorescein dye. We generally take the photo with the eye in primary gaze, with the photograph focused sharply on the margins of the infiltrate, and we do this before we instill fluorescein dye. And we don't over or underexpose the image so that you can get a good sense of what the opacity is, and we try to standardize the angle of incidence of light as well. Next, we put in fluorescein dye, and within the next few minutes, we blot the eye to wipe away excess, and we also have the eye looking primary gaze. And this time, when we take the cobalt blue light photo, we focus sharply on the edges of the epithelial defect. And you'd be surprised how this simple change has substantially improved co-management as well as clinical outcomes for infectious keratitis at our center. And talking to my colleagues around the world, that seems to be universal. So I recommend instituting a universal photography protocol for all infectious keratitis at every single visit at your center. If you don't have a camera, then I think you should get one. Here are examples of bad photos. I think if you're getting these because the patient is photophobic or having difficulty looking straight, you can dim the light, but still try to get a good photo with the eye in primary gaze and sharply focused on the lesion of interest. Again, the infiltrate and diffuse illumination and the epithelial defect edges in blue light. Here's serial photos. So here's the same patient several weeks later. This patient was having delayed wound healing because she had been overtreated with antimicrobials for many weeks on end before seeing us. She had what I call a kitchen sink keratitis, where she's been treated with everything and the kitchen sink. And so we actually instituted a washout period and repeated the scraping, confirmed that this was indeed just a gram-positive bacterial keratitis, and then allowed her to heal. But because of the weeks and weeks of eye drop toxicity, her anterior stroma was quite irregular and uneven, and it was difficult for her to epithelialize, and so she took well over a month to epithelialize. But these are the slit lamp photos we used to serially track her healing until she fully epithelialized. We'll go through specific examination findings and what to look for, but also importantly mistakes to avoid for each of them. I'll briefly touch upon conjunctival injection grading. So I would recommend again using diffuse illumination to standardize documentation of what's going on as far as the eye redness level, which can be a very crude, semi-qualitative biomarker for inflammation in the eye. And certainly steroids can mask infection, but at the same time, for certain cases like acanthamoebic keratitis, we do try to look at the overall level of conjunctival injection as a correlate of how well the infection is being controlled and how much inflammation there is in the eye. And here's an example of an Efron scale, which can be used to grade infection, although I think most infectious keratitis would be on the higher end of the scale. The National Eye Institute has a scleritis scale, which can be particularly relevant for cases like acanthamoeba scleritis or Pseudomonas or fungal scleritis or tuberculous scleritis. And so this is something that you can also try to standardize. And here you would instill phenylephrine and wait a few minutes and then take these photographs to try to quantify how much redness there is in the sclera itself instead of just the conjunctiva or episclera. The epithelial defect is the most precisely quantifiable biomarker correlating with infection resolution. Keywords correlating with. We urge you to use consistent, clearly specified measurement methods for the epithelial defect. You should use photos at every visit. And there are exceptions to that rule of correlation. when reepithelialization lags infection resolution. I had mentioned the kitchen sink keratitis, and neurotrophic keratopathy can also occur with surprisingly high prevalence in these patients, and that itself can delay wound healing, and it can also be a risk factor for infection itself. There are exceptions when reepithelialization precedes complete infection resolution. So there are some cases of fungal keratitis where the infection has gone deep in the stroma, but the epithelium is intact. So the epithelial defect closure cannot be used as a biomarker for infection treatment. And viral stromal keratitis without ulceration and endotheliitis are also obvious cases where the epithelium can be intact. It's important to use consistent, clearly specified measurement methods. This may sound very mundane, but it's incredibly commonly a problem, and so that's why we're talking about it. Here you can call it, you can measure length by perpendicular width, and this is the convention used in the herpetic eye disease study back in 1999 or so. And this is the most commonly used convention in our clinic, but you should specify. Don't just say 8.2 by 5.3. Say 8.2 long or length by 5.3 W or width. The other way to approach it is height by width. And here I would not say width, I would use horizontal. So say 7.8 millimeters horizontal and 5.4 millimeters vertical, but specify which is which and try to not get length and width confused with vertical and horizontal. Do try to specify that because your colleagues are very likely to measure it a little bit differently than you. And that may confound your measurements of whether the patient is epithelializing or not. Stromal infiltrates. And so here you can see the many different phenotypes of infectious infiltrates. This is really the cardinal biomarker for actually assessing how is the infection, how bad is the infection, is it getting better or not. The slit lamp and slit lamp photography unfortunately only allow you to measure in 2D planar dimensions. And here you can assess a few things. What is the diameter and surface area of this? Again, use the same conventions as you would for epithelial defect, would just be consistent and precise and clear in what mechanism you use to measure it. You can also talk about how dense the infiltrate is. You can talk about the margins. Are they sharp, as is the case with successfully treated infections that are turning into scars, or are they still poorly demarcated, which is more true in early stage infection and inflammation. You can also talk about the area of surrounding haze, as you can see in this case. And also you can talk about, are there feathery edges? Are there multifocal lesions or satellite lesions? Are there is there a ring infiltrate? So these are all qualitative terms, but that can be quite useful. At the end of the day, a picture is worth 1,000 words, and I think for beginners especially, it's important to become well versed and precise in the use of terminology. But when it comes to co-managing with yourself in the future or your other colleagues over time, pictures are worth 1,000 words, and you should always get a photo. I want to talk a little bit more about depth of the infiltrate because I think this is, not universally measured, and I think every description of an infiltrate must contain its surface area in 2D, but also its depth. And because depth is one of the strongest risk factors for perforation, endophthalmitis, and therapeutic keratoplasty. And so, in general, it's important to try to measure depth down to the nearest tenth of a percentage, 10 percentage points. But if you're having trouble, as many people do with very dense infiltrates, then anterior segment OCT is a great option. It can tell you whether there's truly a full thickness infiltrate or perhaps just a very dense anterior or mid-stromal infiltrate that doesn't go all the way deep. And since this is such a powerful prognostic sign across multiple studies, at our center, we are increasingly using anterior segment OCT at the baseline visit and at least once a week for tracking longitudinally the infiltrate in infectious keratitis. So here's another case that kind of bridges the epithelial defect and the infiltrate part of the conversation. So here you can answer a question as well. This patient presents with slowly worsening eye irritation, slightly blurry vision. They deny severe eye pain or photophobia. They do endorse sleeping once overnight in their contact lenses. What are your next steps in management? Should you have them stay out of their contact lenses for a few days and wait for the condition to resolve? Should you treat them with topical moxifloxacin? Here's their epithelium, by the way. Should you treat them with topical moxifloxacin to rule out, to preemptively address any bacterial infection? Does this look like a herpetic eye disease where you need to treat them with antivirals? Should you treat them with topical steroids, given that there's inflammation potentially going on? Or should you do some sort of diagnostic corneal scraping? And if so, what specific organisms should you try to test for in your scraping? So the half the audience answered contact lens holiday, which is correct, but not fully correct. About a quarter said topical moxifloxacin, and then 19% of you said corneal scraping. I'm glad that 73% of you are not giving the answer I would have given because I think this is a very underappreciated clinical situation where you can stop a patient from going blind. So this is acanthamoeba keratitis at the epithelial stage of disease. This is a situation where you should learn to recognize the clinical hallmarks of early epithelial stage acanthamoeba keratitis and act rapidly to debride the entire epithelial surface, remove the vast majority of amoeba from the cornea before it goes deep in the stroma or before it spreads to the rest of the ocular surface. And that epithelial debridement is therapeutic. You will cure the infection, you will cure the patient of acanthamoeba in that eye. You should still treat with PHMB for several weeks. However, this is one of those cases where an epithelial debridement can be diagnostic as well as therapeutic, and you've saved this patient from a lot of pain. So acanthamoeba, as you likely know, initially attaches to the epithelium, and then eventually it breaches Bowman's membrane and goes deep into the stroma, where it can cause much more eye pain as well as difficult to eradicate infections. That's the stage at which you can have radial perineuritis, ring infiltrates, and even eventually scleritis as well. Generally does not tend to go inside the eye itself. Um, there are many different phenotypes of acanthamoebic keratitis. If there's one thing I can impart upon you today, it is the importance of recognizing the epithelial stage and not treating it merely as contact lens overwear or as herpetic keratitis. So the first two pictures at the top show isolated epithelial stage acanthamoebic keratitis. Note the granular appearing epithelium with little or no stromal inflammation. They might have a few nummular subepithelial infiltrates, but generally it's not very impressive. And so going back to the photo that I showed, here you can have what looks like it could be a pseudodendrite, but if you look closely, it's not all negative staining. Some of it is positive staining, some of it is negative staining. This is not pooling, this is staining. And so this roughed up epithelium and these looped, sort of almost fractalized looking long arcs and loops of this granular epitheliopathy with intervening spaces of normal cornea as well. And so this is a hallmark of epithelial stage amoeba keratitis. Very subtle sometimes, not a lot of pain. You know, that classic admonition to look for pain out of proportion to exam, that applies to late stage acanthamoeba when it's too late to prevent them from being in severe pain, and they're due for a long course of anti-amoebic therapy. One other finding, which is not pathognomonic, but which is worth pointing out, is this, and it's a little blurry in this photo, but this is the circumferential limbitis. And so this is a very, very early stage of limbitis. It can be easily confused with ciliary flush. But if you have this 1 to 2 millimeter radius of almost salmon-colored vessels that are hyperemic and not much redness elsewhere, then that is limbitis, and that occurs in approximately 10 to 20% of acanthamoeba keratitis, including in some early stages. Again, not pathognomonic, but one of those clues that can tilt you more toward an amoebic diagnosis. Let's look at the rest of the phenotypes. So this is picture C is epitheliitis with radial neuritis. So here the infection has reached the Bowman's membrane and gone into the nerve layer, the subbasal nerve plexus. And so you can see these inflammatory nodules in a linear arrangement along a corneal nerve. This is pathognomonic for acanthamoeba keratitis. Here is anterior stromal disease in panel D with clear surrounding cornea without deep stromal inflammation, but this has breached the Bowman's, gone into the stroma. This patient is going to be on months of PHMB most likely. Here is deeper stromal keratitis. Here you can see the beginnings of a ring infiltrate. And then in panel F, here's the classic ring infiltrate. These can be very dense and classic or faint. But in general, you should always keep an eye out for those. But the thing to know about ring infiltrates is they are not pathognomonic for amoeba. They can be caused by herpetic disease or medication toxicity or other inflammatory diseases as well. If you're having a patient come in with acanthamoeba and they have a ring infiltrate, that was a very delayed diagnosis, and it's going to be a long course to eradicate that infection. So again, the earlier you diagnose it, the better. Depth is one of the most powerful prognostic indicators of successful eradication of amoeba. And so early diagnosis equals less depth. It is also useful to quantify thinning of the cornea in cases of severe melt or concern for impending perforation. You can try to quantify to the nearest 10%. You can try to specify tissue loss, and you should also say, when you say 10% thinning, do you mean that 10% of the stroma has melted, or that 10% is remaining? Because those mean very different things, and you should specify those things as well. And OCT again has a role to play here. It can precisely measure and track thinning, and our own work showed that it can better detect perforations and their associated anterior anatomic abnormalities compared to slit lamp exam. So here's an example of an old, healed keratitis, but here you can see that there are, extensive iridocorneal synechia. You can also, for completely opaque corneas, you can use OCT to verify whether there's a collapsed chamber, focal iris plugging of a perforation that was old. And so that can help with assisting determining candidacy for surgery or planning surgery. Hypopyon is an important biomarker, and I think measuring it instead of just noting the presence or absence of it is very important. It is associated with a risk of endophthalmitis, five-fold increased risk. It is risk factor for needing surgery, 17 or 18-fold increased risk in bacterial keratitis. And height really does matter, so you should measure it. There's a dose-response relationship between height and adverse outcomes in both bacterial and fungal keratitis. Admittedly, it can again be difficult to detect and measure through dense infiltrates that are overlying it. It is again possible to detect and even quantify on antersegment OCT. So here's our own published study showing that you can detect hypopyon far better on OCT, but also you can also measure it in millimeters using a caliper tool on your own OCT machine. Endothelial plaque. So there's a lot to say here. I think this is one of those findings that we're learning more and more about with time, and because of its substantial prognostic significance, as well as the fact that it's underdetected. So it is often missed on slit lamp exam and much better detected on OCT. And our own studies have shown that there's substantial improvement in diagnosis on OCT. It is an independent predictor of surgical intervention in bacterial keratitis, and also an independent predictor of perforation in fungal keratitis with very high odds ratios. And so the thing to know about endothelial plaque, besides its association statistically with needing surgery or having a perforation, is that in the case of fungal keratitis, it actually contains hyphal organisms. And so it represents an intraocular invasion from the cornea into the inside of the eye, which, if it's not treated sufficiently with antifungals alone, is an independent indicator for needing to perform therapeutic keratoplasty. What we're also learning with advanced imaging is that there are some morphological subtypes of endothelial plaque. Now, this data is still incoming, but there's at least two morphological subtypes. One is the endothelial plaque that is contiguous with the stromal infiltrate. So this is, very intuitively, you can see here, there's invasion of the same fungal organism into the endothelial plaque. So it's just an extension of the fungal organism from the stroma into the anterior chamber of the eye. Whereas if you look at the bottom panel, this is a plaque that is distinct. It has a linear margin between the stromal infiltrate and the plaque, and so that is less likely to be fungal. Although again, we need more studies to validate this. The other two morphologies of plaque, which we've noted in our own studies, are flat versus round plaque. The data is still incoming as to the prognostic significance, but there are substantial phenotypic differences, with flat plaques more common in bacterial infections and round plaques more common in fungal infections, although there is still some overlap. And so there's a need for more longitudinal studies of flat versus round plaque, plaque that is contiguous with the stroma versus distinct from the stromal infiltrate, to see what the significance are. But my point is, OCT can detect it much better than the slit lamp, where we are under detecting it right now. And this has the presence of any plaque has prognostic significance, and there's probably additional prognostic significance to the specific morphology or subtypes of plaque that needs to be discovered. Brief word on AI for segmenting and detecting lesions. So AI can automatically segment corneal infection exam findings. Here are different models that can detect all the features that I just talked to you about. And deep learning can differentiate infectious keratitis, non-infectious keratitis, and dystrophy, presumably based on interpretation of the photography-based exam findings. However, and also it can differentiate very obvious active infection versus very obvious healed scar. However, the problem with all of these deep learning and AI-based techniques is that the pipeline for pragmatic implementation in the clinic does not exist yet. As of today, as encouraging as these results are, they are still academic exercises. And so there needs to be a very high throughput, efficient, workflow-friendly pipeline for taking imaging of the cornea, sending it to for interpretation with the algorithm, preferably at the point of care, and then getting a recommendation back as to the most likely diagnosis. And that does not yet exist, although there are teams working on it. All right. Finally, we'll talk about treatment. And so here we're going to talk more about individual subtypes of keratitis, bacterial, fungal, acanthamoeba, and viral. This is all centered on medical treatment, and we'll finish up by talking about surgical treatment. So for bacterial keratitis, for severe cases, fortified antibiotics are still commonly used, but the mistake to try to avoid is indiscriminate, ongoing, prolonged use of frequent fortified broad-spectrum antibiotics like vancomycin and tropomycin, or vancomycin and ceftazidime. In general, what you need to do is tailor the therapy once the microbe is identified and continually monitor for surface toxicity, which can delay reepithelialization and even precipitate melt in severe cases. For mild to moderate cases, fluoroquinolones like ofloxacin or moxifloxacin are broad spectrum enough to have comparable efficacy to fortified antibiotics. The steroids for corneal ulcer trial 1, which just was followed by SCUT 2, which we'll talk about, showed overall that there's no benefit to adding topical corticosteroids. Subgroup analyses were very interesting, though. They showed that nocardia keratitis did worse with adding topical steroids. And so, in general, topical steroids are to be avoided in nocardia, which is a bacteria that behaves more like a fungus in terms of its appearance as well as its response to steroids, as well as its indolence of infection. There was better visual outcomes in severe keratitis, meaning cases that had baseline count fingers visual acuity or worse, and severe ulcers, as well as early starting of steroids within 2 to 3 days instead of waiting 4 or more days. There was another trial done called SCUT 2, which just recently finished. It showed that cross-linking was not associated with increased scar size because that was a topic of considerable interest because of encouraging reports from PAC-CXL. But also SCUT 2 also showed that adjuvant steroids were again not associated with improved outcomes, including in non-nocardia keratitis. Finally, moving on, we'll talk about fungal keratitis. And so here there's 2 trials to know. The mycotic ulcer treatment trial 1 showed that for filamentous fungi, especially Fusarium, topical natamycin has superior visual and anatomic outcomes than topical voriconazole. MUT did not enroll many yeast, such as Candida, which is the most common species in northern climates. But the results are really representing one of the few randomized trials in the infectious keratitis world where one drug is unambiguously demonstrated to be better than another drug. And so these are, at our center, this is evidence that's strong enough to recommend topical natamycin over topical voriconazole for any filamentous keratitis. MUT2 showed that for filamentous fungi, adding adjuvant oral voriconazole did not confer a benefit, and it did increase the risk of systemic side effects. And secondary analysis showed a possible benefit in Fusarium. And so for severe keratitis, some centers do treat with oral adjuvant voriconazole, but the key to remember is that they cause systemic side effects, including hepatotoxicity. And so it's very important to check liver function testing every 2 weeks or so. There is, ongoing controversy regarding intrastromal and intracameral antifungal injections. It can be used in severe cases at several institutions, including our own. High-quality evidence with adequately powered randomized controlled trials remains limited. There are some, copious reports, in fact, showing that there are improvements in the fungal infection with recurring intrastromal injections. But there are, some studies also showing an increased association with melt or perforation or adverse outcomes. And so the data is not yet in. With rose Bengal photodynamic activated therapy, or RBPDAT, there are many encouraging reports that this is a salvage therapy for severe or non-responsive microbial keratitis, particularly fungus, but also amoeba. Clinical use keeps expanding, but more recently, the REAGER trial did not show a clear visual benefit with rose Bengal PDAT for fungus. But then when you look at subgroup analysis of REAGER, what was notable was that there may be different effects by species. So there was better 6-month best corrected visual acuity in Fusarium, worse in Aspergillus. So the efficacy of rose Bengal may differ depending on which species of fungus you are treating. With acanthamoeba, as I said, early diagnosis is critical. Maintain a high index of suspicion based on history. Don't confuse for hepatic keratitis, especially that epithelial stage. Um, for a long time, the mainstay of treatment was biguanide therapy, and PHMB was, thought to be roughly equivalent to chlorhexidine at the zero point zero 0.02 concentration, and that was shown in at least one trial, and then or one study, and then the other study that assessed PHMB 0.02% showed that it was roughly equivalent to dual therapy as well. But that evidence has actually changed in the last few years. And so PHMB 0.08% is a higher concentration than 0.02. And good, well-conducted phase one studies showed that PHMB 0.08 is tolerated well by the ocular surface without too much epithelial toxicity despite its higher concentration. Um, and the ODAC trial out of Moorfields Eye Hospital showed that dual therapy with the old standard of PHME 0.02% and propanidine was equivalent to monotherapy with PHME 0.08%. So PHME 0.08% was non-inferior to the old standard of dual therapy. And medical cure rates in these cohorts actually exceeded 86% in both arms. So that was very encouraging. So at our center, we've switched over completely to using PHMB 0.08% monotherapy as the first line of treatment for acanthamoeba keratitis. Oral multiplicine has a limited role in select situations, so it can be used as a salvage therapy for severe non-responsive cases of acanthamoeba keratitis. But the thing to note about it is that you have to monitor for a very intense inflammatory reaction, which sets in around week 2 to 3. And that is treated with topical steroids, but often it's so severe that it causes necrotizing scleritis, corneal perforation, and in some cases even can precipitate loss of the eye. And so you'd have to be cautious with using oral miltefosine because of that severe inflammatory reaction, which can be refractory to topical and even oral steroids. There is some encouraging reports of cross-linking as salvage therapy. So here's one case that we saw where we did PAC-CXL with riboflavin cross-linking, which did seem to resolve this case of acanthamoeba keratitis, which was not resolving after intensive dual anti-amoebic therapy and topical voriconazole and miltefosine. But again, a larger trial has not been done to definitively show that there is a definitive therapeutic role for cross-linking as salvage therapy for acanthamoeba. Finally, let's talk about medical treatments for hepatic keratitis. So here are the current treatments for the hepatic eye disease study. Epithelial keratitis used to be treated with topical antivirals, and in many countries it still is. In the US, we switched over to oral antivirals due to concerns with trifluoridine's topical toxicity. Epithelial keratitis is just treated with only antiviral therapy. Stromal keratitis is treated with antivirals as well as topical corticosteroids. Iridocyclitis and endotheliitis are treated with topical corticosteroids as well as an oral antiviral, and some centers do supplement that with topical antiviral. And then for preventing stromal keratitis recurrence, acyclovir 400 milligrams twice a day for prophylaxis does substantially reduce the risk of recurrence in HSV keratitis. This trial is now decades old. There are limitations in the evidence. Again, in the US, we replaced topical trifluoridine with oral acyclovir and more recently valacyclovir. There's not yet great evidence regarding the efficacy of ganciclovir gel, although it's widely used as a supplementary antiviral therapy. And then the HEADS results until recently were extrapolated to herpes zoster keratitis and herpes zoster ophthalmicus. We now have the zoster eye disease study, which recently got published, which showed that in a randomized trial of 527 adults with HZO keratitis or iritis in the past year, prophylactic valacyclovir 1 gram a day for a year. When those patients were given that for a year and followed out to 18 months, although they did not have any benefit in terms of time to new or worsening HZO keratitis, when you look at secondary analysis, there was a 28% reduced hazard of new or recurring keratitis at 18 months. There was also a reduced total number of keratitis and iritis episodes at 12 and 18 months. So secondary analysis do seem to support considering 1 year of suppressive valacyclovir for HZO, particularly for preventing recurrent episodes. We'll finish up, since we're running over time, we'll skip ahead to therapeutic keratoplasty, where there's a lot more to say, which means, of course, that I gave away the answer to this question. So here's the last case. Here's a culture-confirmed fusarium fungal keratitis with peripheral spread of the infiltrate and enlarging endothelial plaque has gotten worse despite 2 weeks of intensive topical natamycin and 2 rounds of intrastromal voriconazole. What are your next steps in management? Good. I may have biased the results by giving away the answer, but um, the therapeutic keratoplasty is a valid option. Now, I will admit there are some differences of opinion we've noted in how other cornea specialists would have managed this condition. So I don't want to pretend that TPK is the only answer. You can add another antifungal. You can consider intrastromal injections as well as considering riboflavin cross-linking. So here's a close-up picture of that infiltrate. You'll note a few things, and I'm trying to convey the three-dimensionality of it. So here, the cornea is bulging forward with a thick, dense, full thickness infiltrate. Underneath it, here in the red, is an endothelial plaque. So here you can't tell the depth because, again, it's a photo, but there's a dense endothelial plaque growing along the inside of the cornea. When you look at OCT, it's that phenotype that we talked about, where there's a full thickness infiltrate, but also you can visualize much better on OCT than photography that it is contiguous with this dense endothelial plaque, which is spreading centrifugally over time despite intensive antifungal therapy. And so here we go. And so because this infiltrate was not improving on antifungal therapy, because it was full thickness, where we thought the topical therapy was unlikely to get deep enough to treat it, because we knew that this was fusarium, and based on histopathologic studies in the past, we know that endothelial plaque and filamentary keratitis is much more likely to contain live organism, meaning this patient had an intraocular infection already. Because that endothelial plaque seemed to be growing over time, because we felt that repeated intrastromal injections will only briefly increase the concentration of antifungal drugs in the cornea before reducing again, and they wouldn't have sustained drug delivery to the anterior chamber to kill the plaque where the bulk of the infection was located. And importantly, because this infection was central and there was still an opportunity to cut the whole thing out, we performed a therapeutic keratoplasty in this patient. In general, with TPK, the goals should be made clear. You're either restoring tectonic integrity, or you are trying to resect the infection, or you're trying to do both. Here, our goal was more to resect the infection itself. Often there's a dense plaque here that is adherent to or even invading the lens. And so here we made it a point to trephinate large enough to get the entire infiltrate. If it's a large diameter trephination, that's okay. Your goal is not to help the patient see better. Your goal is to cut out the infection and save the eye, and so that's okay to do. The other thing to note is, again, we sent these specimens for histopathology, but also we went ahead and resent the aspirate of the endothelial plaque for microbiology testing, and we sent a portion of the TPK button for microbiology testing as well. And then the histopathology is, again, very illustrative. It showed septate fungal forms with high full vesicles suggestive of fusarium involving both the stroma and that retrocorneal inflammation, this thing, which we also cut out. So endothelial plaque and fungal keratitis matters. I think it is an important indicator for TPK, especially if it's not getting better on medical management alone. What's also interesting is this patient has bilateral fungal keratitis. So I didn't tell you that he also had fusarium, culture-confirmed fusarium keratitis in his other eye. Here we did not do a TPK. I'll just cut to the chase and say that although there was a small plaque, in general, we felt like this was treatable with eye drops alone. And so we just had him take intensive antifungals in the form of natamycin. And so post-operatively, we continued antifungal medications in the right eye and the left eye, but for very different reasons. Here it was to make sure that there's no infection coming back. Here it's to treat the actual infection that was still there. We also did, for the right eye, we covered with antibiotics until he reepithelialized. We had given oral voriconazole, although we stopped it shortly after the postoperative period. And then we also, because we were not allowed to use topical steroids, we went ahead and gave him cyclosporin, which is a steroid-sparing alternative anti-inflammatory medication, which has been shown to have weak antifungal properties in vitro and may reduce the severity of inflammation and fungal keratitis, although more studies are needed. Here's what he looked like at month one, clear of infection. So at that point, we stopped the oral voriconazole, and shortly after this visit, we stopped the natamycin. We kept the cyclosporin going, and later on, we stopped all antifungals. He was on cyclosporin, and he was also started on steroids for that right eye because the graph remained clear. We wanted to keep it saved. He's seeing close to 20/20 range in this right eye after TPK. His left eye was successfully medically treated. However, what's noteworthy is that the left eye is only 20/40 with a rigid gas permeable contact lens. So ironically, even though this was the more severe case, because we did early TPK and we achieved cure of infection and a retention of clarity within the TPK graft, his more severe fungal keratitis ended up being the better seeing eye in the end compared to the eye with a corneal scar. So I think last thing I'll say, in the interest of time, we'll finish after this, is that the goals of TPK must be very clear. You must, think what is the goal? Is that to restore tectonic integrity? That's achievable in the almost 100% of eyes. Is it to surgically remove the infection? That is achievable in anywhere from 70 to 90% of eyes, especially if you have a well circumscribed infiltrate that has not yet spread to the limbus. The goal can also, in some cases, be to possibly maintain graft clarity and improve the patient's vision. However, you must counsel the patient that that is not our top priority. Our top priority is to save the eye, try to remove the infection, because otherwise you're setting yourself up for disappointment, where you could save the eye but still have the patient be disappointed that they're not seeing better. And graft failure does occur in 45 to 65% of TPK eyes across published studies because you're operating on an inflamed eye. And that's okay if the infection is severe enough to where you needed to do a TPK to save the eye and live to fight another day in the first place. You can always do an OPK later, optical keratoplasty. What's also notable are risk factors for infection recurrence after TPK, meaning you fail to achieve your goal of TPK. Hypopyon, perforation, limbal extension, lens infection, larger infiltrate size, delayed surgery. So all of these, especially everything but hypopyon, all of these are evidence that you waited too long. You looked at the biomarkers, like thinning in the case of perforation. Thinning precedes perforation. Infiltrate spread toward the limbus precedes establishment of infection at the limbus and scleritis. Endothelial plaque precedes lens infection. Infiltrate size can be tracked over time. And then if you delay surgery on top of all these risk factors, that is a risk factor for having such a bad infection that you're not able to resect it. So I actually advocate for I advocate measuring these anatomic findings precisely using detailed exams and serial imaging. Call it what it is. If it's getting worse on you or it's not improving after several, at least 2, maybe 3 weeks at least of sustained antifungal therapy, then declare failure of medical management and make the difficult decision about whether or not to do a TPK. Perforation is not the only indication for TPK. These other biomarkers are very important as well. Do not delay until the infection spreads to the limbus or the anterior chamber and becomes unresectable. Finally, conjunctival flaps. So this is a underutilized option for refractory infectious keratitis, even in pending perforations and deaths of metaceals. And it can be a salvage or it can temporize and stabilize the situation before a future optical PKP. The largest case series, one of the larger ones was from Bascom Palmer in the last year or so, where they did 43% complete flaps and 57% partial flaps. And partial flaps actually tended to have higher success and faster resolution, potentially because there's a greater carriage of vascular supply to that area where the flap was sutured. There's another earlier series from 2020 where 71% were for active infectious keratitis and 97% were for ocular surface stabilization. The thing to know is that this is a salvage therapy that can be used to try to further improve infection control and stabilize the situation. And again, live to fight another day so that you can do optical rehabilitation later after a flap takedown. So in conclusion, microbial keratitis diagnosis and management can be challenging due to ambiguities in diagnosis, ambiguities in clinical assessment, and ambiguities in treatment. Achieving clarity on all of these three can help improve clinical outcomes. And so I would encourage you I hope you can use this lecture to try to think more clearly about all these things, diagnosis, assessment, and what are the goals of treatment and what are the best approaches to try to achieve those goals. Some of these things that I discussed were elementary, admittedly, but that's precisely why they are so important, is because they're fundamental to having clarity of thought as you approach care of these complex patients in these very ambiguous situations that are very high stakes. I hope that was helpful. Thank you for watching. So now what I'm going to do is I'm going to go, there's 32 questions. I will go in chronological order and answer all of them because we have about 20 minutes left. And Orbis folks, let me know if I'm taking too long. How do you perform an evisceration? So that is a little bit beyond the scope of this lecture, so I'll table that for now. But I think I would refer you to the Orbis CyberSite lectures on enucleation and evisceration. And there are also techniques, papers available online as well as videos on YouTube. How about a glue patch and impending perforation? Can this be an option in low resource settings and no access to an eye bank? Absolutely. So we didn't have time to talk about surgical interventions for severe infectious keratitis, but yes, a patch graft, as well as gluing, as well as amniotic membrane, as well as certain combinations thereof can be an excellent resource to use when you don't have fresh corneal tissue available. I would also highlight the potential utility of gamma irradiated sterilized corneal tissue, which can be off the shelf and used, kept in a freezer or even kept dry in some cases and used for patch grafting as well. But depending on the size of the perforation, for very small perforation, you can use gluing. For small to medium perforations, you can use gluing an AMT or corneal patch graft with sterile tissue. And for larger macro level perforations, you may need to use live tissue. And conjunctival flap is somewhere in between. Related to the period of medical therapy, what's the time for PKP? I'm going to interpret that question to mean when should you call it medical treatment failure and do a TPK? That's one question. The other question is how long after you treat the infection can you do an optical TPK or optical keratoplasty? So when you look at how fast the biomarkers we talked about change, for bacterial keratitis, it's usually about 1 to 2 weeks. Within 1 to 2 weeks, you generally start to get a sense of is this patient getting better or worse. For fungal keratitis, it can be longer. It can be 2 to 4 weeks. For acanthamoeba, it's on the order of at least a month in many cases, although you can see earlier improvement. But in general, you should be patient enough to wait 1 to 2 weeks for bacterial before calling it treatment failure, possibly longer. You should be patient enough to wait 2 to 4 weeks for fungal, unless, of course, it's very severe and you think there's no way I'm going to be able to treat this with eye drops or intrastromals alone. But generally, if it's an ambiguous situation, you should wait about 2 to 4 weeks before saying you've met the criteria for therapeutic failure with medical management alone. And for acanthamoeba, you should wait a bit longer because you can have this prolonged treatment with PHMB 0.08 concentration for many weeks. And then at that point, the infiltrate starts to finally recede, the inflammation starts to go away, and the patient gets better. For optical keratoplasty, in general, we at Hopkins wait 6 months after resolution of the infection and stopping of antimicrobials before we do optical keratoplasty. And if there's neovascularization in the eye, then that makes us potentially even wait even longer to try to optimize the graft survival. How long should we use prophylactic acyclovir 400 milligrams BID? That's a good question. So I think in general, the clinical practice based on the HEAD study is to have long-term prophylaxis for patients with recurring herpetic keratitis. Certainly the ZED study for suppressive oral valacyclovir, they were treating the patients for only a year, but that doesn't mean that you would only treat the patient for a year necessarily. For herpetic keratitis, generally we treat them forever with suppressive acyclovir if we are concerned about recurrence over their lifespan. I answered the question, how long must the treatment of acanthamoeba keratitis last to see an early improvement? In general, for acanthamoeba keratitis, I think you need to counsel the patient upon diagnosis that they're going to have several months of therapy. At our center, we tell them at least 6 months of therapy of intensive anti-amoebic therapy, after which there may be up to 6 more months of lower dose anti-amoebic therapy just to eradicate any infection, any cysts or trophozoites that are lingering on the ocular surface. So that's up to a year of therapy in some form. 6 months, very intense frequent eye drops, 6 months of QID, eye drops in order to really definitively eradicate the amoeba before we consider keratoplasty. Can we do conjunctival flap in a non-healing ulcer or bacterial fungal keratitis? I answered that question. Yes, absolutely. If it's a macro level perforation, your hand may be forced to try to send them to a center where there's enough tissue for tectonic rehabilitation. But yes, you can do conjunctival flap. And in some cases, you can also incorporate tendon fascia as additional profibrotic support because tendons can biointegrate into the stroma as well. Um, from which tissue is patch graft taken? Live, like recently deceased donor corneal tissue that's not viable from the eye bank is fine. You can get gamma irradiated or sterilized tissue as well. Um, can you use amnion and hypopyon presence? Yes, so long as you can see the hypopyon and measure it over time. Best management for nummular keratitis. Great question. Taper your steroids very slowly, probably slower than you think you need to avoid recurrence. Be patient with it. It can take several months. Get them very slowly tapered off to prevent recurrence of these subepithelial infiltrates. All right. How can we take a sample for diagnosis? Scrape deeply. Can the secretion use a sample for diagnosis? I'm not sure what that question means. But generally, scrape deeply, use a speculum, only use one numbing drop if obviously more if the patient needs it, but be sparing with numbing drops and then scrape very deeply. If we did a conjunctival flap, will it increase the chance of rejection of PKP in future? Great question. There is going to be more neovascularization in the cornea after the conjunctival flap. In general, we do the conjunctival flap takedown, allow the patient to reepithelialize for a bit, for a few weeks to really a few months, and then we consider the optical PKP. Hypothetically, I think the answer is yes, there would be increased neovascularization and therefore a greater risk of rejection of the PKP. There's not great data, to my knowledge, to definitively answer that question, but that's a good thought. Please discuss further about any early acanthamoeba keratitis, considering it attacks the nerves, pain out of proportion is a hallmark feature. Why did the patient not experience pain? Is the lack of pain in early AK a very common feature? Yes, it is. So the one thing I was trying to impart is that is, that early stage epithelial amoeba, they're not in pain. They don't have radial keratinoneuritis. They don't have a ring infiltrate. And so they don't meet that textbook definition that you learn about in elementary level microbial keratitis teaching. And that's precisely why they're underdiagnosed by optometrists as well as ophthalmologists. And so in early AK, you do not necessarily need to have a lot of pain. You can just have this vague irritation in your eye that's kind of getting slowly worse over time. Maybe it got worse, particularly after starting topical steroids. But that vague, indolent, non-resolving pain, along with that granular epitheliopathy, maybe a couple of subepithelial infiltrates in a contact lens wearer that has been misdiagnosed as contact lens overwear or herpetic keratitis. That is the typical phenotype and history of epithelial stage disease. Is there a role of cyclosporin in the management of keratitis? Potentially, yes. We've incorporated into our fungal keratitis protocols, especially for eyes that are about to get TPK, as a steroid sparing therapy, since we cannot treat the post-TPK eyes with steroids because they might make the fungal keratitis worse if there's any fungus left. As I had mentioned, they can somewhat reduce inflammation, and they also are shown to have weak antifungal properties in vitro. That being said, we do need more long-term studies with greater sample size of patients, and ideally also a randomized controlled trial to try to figure out the role of cyclosporin or even topical tacrolimus, which is even stronger than cyclosporin, for management of fungal keratitis in particular, especially after TPK, I think. Comment on the role of topical chlorhexidine drops for fungal keratitis. So I think in general, there's been one RCT, I believe, evaluating chlorhexidine versus natamycin. Natamycin was superior. So in general, if you're able to get natamycin or natamycin for filamentous fungal keratitis, the data is pretty unambiguous at this point. It's one of the few situations where you really have multiple RCTs, one from Arvind, one from Ames in India, showing that natamycin is better than voriconazole. And I believe there's at least one other trial from Nepal showing that it's superior to other antiseptic medications. And so natamycin should be your first line of therapy for fungal keratitis. How to taper down steroids. What is the use of steroids to decrease the scar? We were really hopeful that SCUT-1 and then SCUT-2 would show a reduction in the scar with use of topical steroids. Thus far, the papers that have come out have not shown a quantifiable difference. Um, all I will say is when we start steroids in our practice, and there are some differences in how people do this, we start them very gingerly. So we won't start them right away in a bacterial keratitis. So we'll never start them in fungal or suspected fungal. We'll start them after a few days of antibiotics and non-nocardia bacterial keratitis that's been microbiologically confirmed. We will start at maybe BID or TID just to make sure they don't get worse. And then after a couple days, go up to QID or 4 times a day, and then keep them on that for several weeks. And then gradually taper down to BID for a few more weeks and then stop it. For acanthamoeba, steroid use is controversial. There's a parasitic ulcer treatment trial ongoing that is trying to assess whether adding adjuvant topical steroids after 4 weeks of PHMB might reduce inflammation, possibly even improve visual outcomes in acanthamoeba. I know at Moorfields Eye Hospital, they feel very comfortable after a few weeks of PHMB starting topical steroids. We are enrolling for the PUT trial, so we're randomizing patients one way or the other. But at our center, I personally do feel comfortable doing PHMB 0.08% for about 4 weeks and then considering starting topical corticosteroids. I know others feel differently. There's not great evidence to answer that question. At what frequency can intrastromal voriconazole injections be given? Very divergent opinions here. Some people think they're not helpful and harmful. Other people are big fans of them and take patients to the operating room or the procedure room repeatedly for them. I think in general, without disagreeing too much with these vehement, strong opinions, I will say one of the biggest failure modes in keratitis is doing the same thing over and over again and expecting different results. That's not a helpful thing for the patient. If you're doing repeated intrastromal injections over and over again and not seeing meaningful improvement in those biomarkers we talked about, then it's probably not going to work yet another time. You can go to the OR multiple times, maybe even 3 or 4 times, but if you're having repeated trips to the OR or just repeated procedures with intrastromal injection and it's not working, then don't keep doing the same thing over and over again and expect different results. Which one is better, oral or topical antifungal for suspicious fungal keratitis? Topical. Um, I'm less than a third done. When to start prophylactic fungal treatment in a low setting with low incidence of fungal keratitis? Great question. I think this is why culture and microscopy are very important. We generally do not start prophylactic antifungals at our center, but that's because we have data showing that 85% of our infections are bacterial. 80% are bacterial, 10% are fungal, 5% are amoeba, in that range. And so, based on the epidemiologic data at our center, we don't see a role for prophylactic antifungal unless there's extremely strong clinical suspicion. But even there, I prefer microbiologic testing before doing antifungal treatment. You will find different opinions at different centers that have a much higher proportion of fungal keratitis. So in South India and even other parts of North India, there's a close to 50% or even greater than 50% proportion of keratitis that is fungal. I think in that case, based on the epidemiologic data, is much more justifiable to start prophylactic antifungal treatment along with antibacterial treatment. So it depends on your local epidemiology. What kind of steroid do you use for corneal ulcer? Low potency or high potency? I use medium potency. I think low potency is too low. I don't like high potency personally because Durezol anecdotally seems to have been associated with precipitating corneal melt, at least in herpetic keratitis. And the data, at least from Durezol in the SCUT-2 trial, was not particularly impressive as far as changing outcomes. And so in general, if we're going to do treatment with steroids, we'll use prednisolone acetate, which is roughly equivalent to the prednisolone phosphate that we use in the SCUT-1 study. But that being said, I don't have strong opinions here. I can just tell you what we do in the absence of great evidence. Describe clinical presentations, symptoms, and signs of microsporidia keratitis, including treatment. So microsporidia at the epithelial stage will have these stuck-on lesions that are spaced out. And they look almost like Tygason's superficial punctate keratitis. Whereas in deeper infections, you can have multifocal infiltrates that have more of an immune reaction appearance. And so that can be like these very faded edges. There are very good review articles as well discussing very particular hallmarks of Microsporidia keratitis, like an intervening clear space between inflammatory lesions as well. And I would encourage you to look at those as well. But this is one of those atypical keratitis cases that we didn't have a lot of time to get into, but that phenotype is really worth knowing. How to taper down antibiotics when used as treatment and prophylaxis? That's a really important question. So, um, in the early stage, you should treat intensively. When you see the patient and you diagnose them with their presumed infectious keratitis, and you're giving them their medications for the first time, or they're getting the medications, have them do a loading dose. So every 5 minutes, put in drops for the next 15 minutes just to get that drug concentration up in the cornea before they go home. And then, uh, patient compliance and ability to adhere to the recommendation notwithstanding, we have them in the early stage do the drops every hour for severe keratitis, maybe every 2 hours. And then the question then becomes, how do you treat them overnight? In those first few days, we do try to have them take it every 1 to 2 hours overnight. We need to be humane. I mean, these patients are already suffering from severe pain, and then robbing them of their sleep is, even more inhumane. And so we have to keep their sleep deprivation in mind. And so, over the next, coming days, unless the keratitis is very, very severe, we do try to have them taper down to taking maybe 2 or 3 installations of the medication overnight. And then as the keratitis seems to improve, then we can say take it once or twice overnight, such that they get at least chunks of like 3 hours of sleep or 4 hours of sleep. Um, I think there's not a standardized protocol for tapering the antimicrobial therapy. All I would say is, there's a few considerations. The biomarkers you look at are, is the epithelial defect closing? Is the stromal infiltrate becoming less densely opaque and less purulent looking and more gray, a little bit more transparent and faint, and a little bit more of a rough fibrotic texture, meaning it's turning into a scar? Are the edges of the infiltrate not as fuzzy, but maybe sharpening, because that's an early indicator of contraction of the infection and inflammation? Those are things we use to try to taper down the antibiotic. One thing I will say is antibiotics in the last phase are not tapered, down to twice a day or once a day. They're tapered down to QID, and then when you feel like the infection's gone, then you just stop it. That's it. You don't need to go taper them, QID, TID, BID once a day, like you do with steroids. And so you'll start with very frequent use of eye drops, go down gradually in a way that I'm having trouble summarizing for you because it's really patient dependent based on how the biomarkers are doing. And then the last phase of infection control, you do QID for a few weeks, and then you just stop it altogether. If there's a persistent epithelial defect, we'll keep the moxifloxacin or other fluoroquinolone going for 4 times a day until it closes to prevent bacterial superinfection. Um, an important thing to note, an important failure mode to avoid is excessive fortified antimicrobial use beyond the necessary period. So if you're seeing those biomarker changes that I described that are indicative of infection resolution, and yet you're keeping on, every hour or every 2 hours fortified antibiotics or antifungals or all of the above, you're going to end up with that kitchen sink keratitis where you're throwing everything in the kitchen sink at it, and you're going to have this mushed, opaque anterior stroma. And you're going to have trouble resolving the epithelial defect. And so we do encourage tapering there. I was not able to answer all of the questions. I will try to look through them, and you can feel free to reach out to me as well if you have any questions, and I'm happy to answer them. Thank you so much. Oh, one final question. Okay. Um, Let me choose one that is particularly, they're all really great questions. I'll answer one just because I have a strong answer there. How wise is it to wait and just give saline wash for a few days in case of keratitis? If you're suspecting an infection, I would not merely try to wash it out and hope the host immune response resolves it. I would treat with antimicrobials empirically, at least, if not targeted based on culture. So that's the last question I'm able to answer today. But again, thank you for your time.